Thank you very much. Thank Entort for giving the opportunity to discuss this very, very important thing. Unfortunately, I have to speak before Dr. Sumita, who was to talk on the pharmacological aspects, so I was to cover areas which are still unanswered. So we'll go through unanswered questions, and maybe some of them, maybe Dr. Sumita will come and respond to. So we don't know why myopia occurs. We still don't know. There is no clear study that can give us proof as to why over the past 30 years, across the world, irrespective of race, myopia is progressing. It does not matter which part of the world you are in. It does not matter how long daylight hours there in that country, from north to south, across all continents, myopia has shown a distinct progression across the world. Unfortunately, some areas we have seen a far greater progression, particularly East Asia, where the prevalence is almost 70 to 90% in 5 to 15-year-old children. So imagine a class of 50 children with 5 children not wearing spectacles only. So that's the kind of impact that's happened world over, including India. So we have been seeing a progressive increase in the prevalence of myopia in our children, generation after generation. We know in 30 years the genetics has not changed. So there is very, very clear understanding that myopia is probably the youngest lifestyle disease to affect human beings, and we must treat it as such. As I mentioned, genetic factors have not changed. There was a very interesting Singapore study which evaluated the prevalence of myopia in the Indian immigrants. In the first generation immigrants, it was about 13%, which is corresponding to what we expect the myopia to be in affluent Indian urban children. But the moment the second generation came, the myopia jumped from 24 to 26%. So you can imagine that it was the new environment that the next generation was brought up in, and not really the genetics. There are a lot of still, despite outdoor is something that we have been talking about. Dr. Jyoti also mentioned about it. It is probably the single most important thing that we need to mention, but still, there are questions. How long is effective? Most studies have said about 1.5 to 2 hours of outdoor activity. Now, it does not necessarily require them to be in active sports. Essentially, be there in outdoors in bright light. It does not necessarily mean in bright sunlight. In a country like India, in the afternoon, you can't just send your child out. He'll have to require admissions and IV fluids. So outdoors in adequate illumination, even in a covered area. You can even ask the child to read on the balcony, read on the terrace. So outdoor illumination, how long, we're not sure. What is the luminescence levels? Again, these are controversial, but still we know that any outdoor activity of about 1.5 to 2 hours will help. Amount of near work. Again, there is no very direct, clear evidence and correlation between the two, but we know that what has changed in the past 30 years in East of Asia, and something that is progressively changing in India in the past 10 years, where we have seen a spurt, and again another spurt that we saw post-COVID, is probably related to the excessive use of near devices, digital devices, where you're keeping them so close to your eyes, particularly your phone. So these things have to be stopped in children. These children were never supposed to read on a phone. They were supposed to go outdoors and play and read for only modest times. Now, the attitude has changed. 2 years ago, before COVID, parents would come and say, my child sees television for 2 hours. Please stop him. Today, the parents come and say, my child is on the phone only for 2 hours. So you can see the sea change in the attitudinal difference. Now, 1 year, 2-year-old children have their own tabs and phones to play with. So it's something that it's a ticking time bomb that we are sitting on. Of course, the other problems of risk of sun exposure, feasibility and implementation in a country like India in summers, as I mentioned, it may be really difficult. And the role of vitamin D. It's confounded. Many studies have said vitamin D has an association with myopia progression, but it is a very, very close confounder with outdoor activities. We don't know. The next thing we don't know is how is atropine working. We know across the world, except in a few Caucasian studies, atropine is shown to be very, very effective. 0.01 is found to be effective in almost all studies to a greater or lesser extent, but we still don't know how it works. We had found amount of atropine penetration in the cornea, in the vitreous and the aqueous to be of substantial measurable quantity. We do not know whether there is a direct correlation, but at least we know that it is reaching up to the posterior chamber and may possibly be affecting on the choroid and the sclera where it is supposed to act. The other important thing to remember is there are some anterior segment changes that can be seen with the use of atropine because of relaxation of the ciliary body. So some amount of myopia is adjusted for by that. That is why possibly there has been that continuous dichotomy between reduction in refractive error and reduction in axial length that is seen all across. So part of that correction may be due to the anterior segment changes. This is the possible cause of disconnect and possibly may be responsible for some rebound. Again, this does not mean that atropine does not work. It just means that we have to understand the impact in every child, and now axial length progression becomes the key important thing. Dr. Jyoti talked about peripheral refraction is mandatory. I would say that the evidence is still out. I do not think that at the moment it is mandatory. Most studies that have used spectacles have not actually released their peripheral refraction data. The theory is that there is hyperopic defocus in the periphery, and that is causing myopic progression. But we've seen these lenses work in all kinds of refractive errors, peripheral refractive errors. So it's the bad news that we may not be right in our hypothesis that it's peripheral hyperopia that is driving myopia progression, but the same thing is good news that you can use it in any kind of patients and probably get impact, maybe to a lesser extent, but still it is effective. We still are understanding amount of progression on treatment. We know that younger children do poorly. Our response is poorer to atropine and possibly to spectacles also. If they have had a high baseline rate of progression, again, they may respond poorly. If the response to the treatment is poor, you need to decide whether you want to supplement another treatment. You add an optical or you want to replace it completely if you do not find your treatment working. It's just like glaucoma therapy. You start one drug at a time, you see the response. If the response is not so good or not up to your mark or not expected rate, you switch to another drug. If the response is modest, but you still want more effect, you may add on another intervention. So we have interventions available, and we've seen many of them augment each other. When will we stop treatment in these children, especially now that we are starting treatment in younger and younger children? We're seeing children 6 to 8 years old who are progressing. So we start treatment then. How long? We have safety results of up to 5 years, but what then after? So it becomes very difficult to decide. It is a case-by-case understanding. In younger children, we may even have to continue to 5 years, taper and then stop and maybe follow them up. If there is recurrence, maybe switch to another therapy or restart. In older children, by the time they are old enough, when we know that they are leveling off by 15, 16 years, you may think of weaning off atropine or start reducing their use of their optical therapy. No definite rules. At the moment, there is no clear categorization. I use that this patient, these characteristics, I use optical or I use pharmacological. But bottom line, obviously, ocular surface, poor contact lenses is contraindicated. Very high myopia, high cylinders, as Jyoti mentioned, we can't use opticals. We'll still have to go to pharmacological. If he has decreased near vision, accommodative lag, avoid atropine, he may have worsening of it. And obviously, economics is the background of it all. Atropine drops are very cheaply available. The optical lenses, glasses may cost up to 18 years or more. I hoped we had Migyoung Hee here. He's one of the pioneers of red light therapy, but otherwise also in his absence, we'll just discuss red light therapy. Pre-myopia, a lot of discussion has gone on. Our understanding is that if you find a child of pre-myopia as defined specifically, with a child with risk factors, with borderline hyperopia or young, less than expected hyperopia, I would still say we advise lifestyle changes and try and impact his progression accordingly, and then think of intervention if we have. There are a lot of questions that are still unanswered, and I think with this discussion and maybe in future research, we will be able to understand. So in conclusion, research is going on. We hope we get more and more interventions. Management should be individualized, and patients and parents we should have informed discussions with them and advise them about outdoor therapy, outdoor interventions, as well as the long follow-up that is required. Thank you, everybody, very much for the attention.
Thank you, Dr. Rohit. And next, if there is any questions, we can take it. And by the time, I will request Dr. Sumita Agarkar to please come on stage for her presentation on how effective is atropine treatment.
Atropine treatment, we continue for 3 to 5 years. But yes, the rebound phenomena is also seen once we stop the atropine. So is it there we should continue 3 to 5 years, or can we continue for many years, 8 years, 10 years, up to 15 years of age if we continue? Suppose we have started in a child at 6 years of age, and then after 3 years, if we stop, again rebound phenomena will occur. So I think atropine can be continued up to 15 years. Will there be any harm if we continue till
There is
15
no
years of
evidence
age?
that, you can continue it for whether there will be any harm or not.
Sir, absence of evidence does not mean
Does not
evidence
mean-
of absence.
yes.
So we do not know what we are doing. So the receptors where atropine is supposed to act through were not sitting for us to intervene in. So they have a role. We don't know what's going to happen in the long run. That is why at the moment we have long-term studies of 5 years.
Not more
And
than that.
it is important that we consider tapering them. Rebound is not 100% evidence that it will occur in all cases. So a percentage of children would have stabilized by then. So if there is a rebound, you start thinking of recurrence, repeat therapy, or you think of an alternative therapy. But as I mentioned, because we don't have enough evidence of very long-term therapy, and these children are going to live for another 60 plus years, we cannot say categorically that just because there is no side effect today, that throughout his next 60 years of his life, he's never going to suffer from an intervention we have done when the eye is
60 years,
developing.
of course, not required. Up to 15 years or maximum. After 18 years, myopia is not going to progress. Another
That is
question-
true, but like I mentioned, sir, we do not have evidence at the moment that there is safety enough, and in fact, the drug is at the moment still not FDA approved. It is approved in India, but it is not even an FDA approved drug, atropine, low dose atropine. So obviously they are waiting and collecting safety data before they will allow any drug like this to be used in children for a very long period of time. So that is why anything we have to use with caution. Just because, as I mentioned, there are no hard side effects immediately, it is not that there will never be any side effects with a drug like this.
How earliest we can start atropine? Because myopia, where there is a family history, we can do axial length and we can detect even at the 3-4 years of age when child
It's
is
difficult
there.
to do axial length at 3 years of age. It is
Unless you do any.
We
very,
can do-
very difficult. You can induce the baby and do the axial length under general anesthesia, but would parents consent to give anesthesia?
3-4 years, there is no need of general anesthesia. We could do,
Yeah.
I'm doing.
If you
at
can, you
4 years
can.
of age.
If you can document the evidence that axial length is progressing, you can give atropine.
So 4 years, 5 years, there are studies. 5 years have been a documented study. 4 years, some people have tried. Again, you do not treat myopia with atropine drops.
treat progressive.
You treat progressive myopia. So if you have a child, uncommon, but yes, if you have a child, younger child, with progressive myopia, you can consider. Evidence is not there, but again, it is not
Progressive
necessary.
myopia only because progressive myopia, there is a genetic history. Earlier also siblings has occurred and now this child is there. So I'm talking progressive only.
So
So we
again,
can start at 4 years of age. yes?
you can start at 4 years. Again, if you have evidence of axial progression, sir, remember, there are in that age group corneal changes also which may mimic refractive error progression, which we must rule out. So if you have documented axial progression, yes. At the moment, we don't have data for outlying outside the 5 to 15, 16 years age, but again, anecdotal evidence exists, people have tried, and it should be relatively equally effective. There is no reason for it not.
I think we have a talk on diluted atropine only.
Yeah, I
Dr.
think
Sumita ma'am.
we'll